You're listening to The Dental Guys, Episode 3, 15 Minutes and a Sickle Scaler. This week, we invite a dental hygienist to discuss Perio protocol and how it's changed over the years, the rant of the week, and Jon and Wes get some exciting news at Speer Education. It's all coming up this week on The Dental Guys.
Welcome to this week's episode of The Dental Guys. I'm Jon, the Dental Guy.
And I'm Wes, the Dental Guy.
And man, it has been a pretty awesome couple of weeks, Wes. I mean, wow. You know, last time we talked, last show, of course, you know, we were preparing. And I don't, you know, you get excited. We geek out about stuff like this. So we were very, very excited about our trip to Speer Education. And, you know, it did not disappoint. So we'll get to that in a minute. Tonight, we have a pretty exciting show for you that we prepared. We've been working on this show, thinking about this show for a long time. We got some interesting topics about Perio. And before you turn it off, if Perio bores you, just wait, because it's going to be actually pretty interesting. I mean, I promise. We actually have a real live hygienist, and Laura, and she's going to be with us live. And she's going to be with us live in studio with everyone tonight, talking about practical aspects of Perio, what we do in our practices, and so we're pretty excited about that. But, you know, getting back to our trip to Speer, I mean, wow, you know, so amazing. And, you know, rather than me talk about it, I just want to show you a video that just kind of sums up some of our experience at Speer. So Wes, let's roll that video. Hi, I'm Jon, the Dental Guy. On behalf of Wes, who's recording this right now, we're here at Speer Education in Scottsdale, as we told you guys from the last show, and we made it out. We've just finished up facially generated treatment planning, which is the first workshop in the Speer Education series and continuum. And man, what a few days it was. It was pretty amazing. It definitely exceeded our expectations, which were pretty high expectations to begin with, so that says a lot. So what did we get out of this? I think I'm going to try to give you my top three highlights maybe of this last few days, and this is kind of from both Wes and I. The first one, you know, I would say it's just one of the reasons we came to this is to get a systematic way to treat our patients, each and every case, whether it's simple or complex. And we definitely got that. We got the foundation of how to treat every patient, how to look at every case the same, which is exactly what we wanted the foundation from. Second thing we got was that I think was a top three, was just understanding how to do a really thorough joint and muscle exam. That's something that I've done, but really this is a whole other level of understanding of what to look for, what to look at, how to really analyze a person's muscles and joints to be sure they're healthy and ready for treatment, or to analyze their pain and to know why or what to do. And then another just big thing, probably rounding out the top three, is just going through just a great lecture to finish up from Gary DeWood about believing that your patients want what's best for them, and how to really take that to your team and get your team behind you, making sure that every patient gets the opportunity to ask you for your best dentistry. And that's something that, you know, you can do high quality, but if patients aren't asking for it, then you're not doing dentistry. And so that's really been something that, you know, we know how to do a lot of these things. We've done them, but getting people to ask for them, how do you do that? And Gary just really emphasized that and encouraged us on how to do that. So it's been a great few days. We've got lots more that'll be coming on the shows from what we learned, and some interviews from some faculty here. It's been a great few days. And so for Jon and Wes here, the Dental Guys in Scottsdale, thanks for watching.
Man, you know, we recorded that right as we walked out on the last day. And even just listening back to it again, and I've listened to it several times since I cut those scenes together, and then coming back and applying the knowledge that we obtained there, man, epic. I mean, literally practice changing. Now, we had already, like you said, we've already been doing some of these things for years, but it's a systematic way of treatment planning and looking at every case. And I think I texted you the very first day I got back, and I was like, oh my goodness, like I just diagnosed what was going on with this guy.
Yeah. All of a sudden you start seeing things. And again, it's not that we weren't doing anything here, but you're seeing things now, and in Speer, you almost sound like a drone or something, because you're like repeating the things that they say, but it's really true. You can only treat what you can see.
That's right.
And once you see things, you can't unsee them. You have to, and that's a good thing. You have to treat them, but it also means you have to really think about how that's going to change your practice, because it has to change your practice if you want to do things. So pretty
so
awesome.
Excited. I've got to play another video here, guys. But this is just a little montage of what happened. Now, we talked about having fun times. I took part of my dental team out there as a reward, and so they got to experience some fun as well while we're studying. They're out having a great time. And so I'm going to roll the video right now.
Thanks for watching. Yeah, so, as Wes said, his team came out, some of his team. I'm going to the ADA meeting with my staff this year, but man, I don't know. This probably trumped what they're going to get to do in DC. So, a lot of that was them, but then those videos of the desert, you remember we talked about Tom cars. We talked about it, and we totally, oh man.
Israeli military vehicles, guys.
Yeah, that was not disappointing. That was definitely not disappointing. And the only thing we wish is that we could go faster than what we could, and because they could just take it. It was like nothing to those things.
The thing about that is that I know they can't take a chance on like doing something like that,
right?
And I kind of thought at the beginning, I thought, I don't know, man, this is going to be kind of like weak, because I've got it side by side. I've ridden 4-wheelers growing up, and but it was a blast because you were in the desert, and I'd never been in that situation before, and cacti everywhere, as my daughter would correct me in saying.
That's right, get it right.
I mean, we saw all kinds of wildlife. I mean, it's really, really cool. So if you ever get an opportunity, thumbs up for that place. It was awesome. It was awesome.
Yeah, for sure.
And we'll put a link down in the description below of where you can go, because this was TripAdvisor highly rated, and I will say that it was definitely worth the money and expense. It was awesome. Yeah. It was awesome. So leading right into what our main topic is today, I have sitting beside me not only my wife, but a dental hygienist. And this is Laura. And she's been married to me for, since 2001. So I was getting ready to try to figure out the 14 years, right? And so she started practicing with me. But Laura, just tell us a little bit about yourself and your experience in dental hygiene.
I went to West Virginia University, and I got a 4-year bachelor's degree in dental hygiene. I felt like I got an amazing education at West Virginia University, so there's the plug for them. What was great about that, though, is that when he started dental school is the same day that I started dental hygiene school, and we went through the program together. So a lot of our patients that we shared as students, we shared patients back and forth. I would clean their teeth, he would treat their problems, and it was great. So I already knew how to work with him before I actually worked with him.
So when we started private practice in 2004, my wife and I sat down and tried to come up with what we felt like was the best way to treat periodontal disease. And at the time, she had been practicing. I was in residency and what she had been practicing, she had already taken some CE. There was some soft tissue management CE that she took up about an hour and a half from where we were at. And that really got her excited about treating periodontal disease. And from being a bachelor degree, dental hygienist, you don't just float through dental hygiene school in the program that she was in. It was pretty intense. In fact, I was going to her saying, how do I treat this patient? What are you all being taught on the hygiene side about how to do things? And so from there, with her knowledge and then my knowledge from the doctoral standpoint of pathogens and how to treat bacteria, and her knowing really more about how to use instrumentation that I even did, as dentists that, hey man, if a dentist cleans your teeth, it's probably not as high quality as a skilled dental hygienist. I mean,
right. Just not the same number of reps. They're doing it all the time.
I mean, they're better at it.
No comment.
So anyway, so we came up with some protocols that we felt like that over the years have led to some really, really good results. Now, before you go into that, let me just say that I think one of the things that got us interested in this topic, as far as protocols, it all comes from, because I know a lot of our listeners or people that are watching might still maybe either be in a practice that's their practice that has not really been treating a lot of perio, or has been doing perio kind of the way that perio was done 20 or 30 years ago, which was, the approach was save the tooth at all costs. And there was some really good stuff that came out of that, because people learned how to save teeth even at great cost. And people kept their teeth for a long time. And there were good and bad things about that, but now things have changed dramatically over the last 10 or 20 years. And we know that a lot of that is because of understanding of perio and progression and how it works. But it's also, I think, largely been driven, I think, for me and for Wes, has been from an implant perspective, because now we look at perio completely differently. We're not trying to save every tooth forever. And so as people are listening, it's interesting, you might be in the boat of thinking, okay, well, how do I take my practice to that point where, where do I go with that? When I'm talking to my hygienist about perio, maybe I've been always talking about sending to the periodontist, because, we're trying to save teeth here, and we don't really do a lot of implant dentistry. Or maybe you are doing implant dentistry and but you don't really have a good perio program in your office. And I'll tell you, that's one of the biggest, sources of implant patients I know in my office, I know in Wes's office, is perio, because people buy into the fact that if they've seen teeth be lost over and over and over again, or maybe even in their family, the sense of hopelessness that they get from that, now they actually get some hope. And so I think that a lot of this discussion is, number one, how do we do it? How do I do it? How does Wes do it? And how does Laura do it? But also, how does the approach change when you take into account implants? What did we used to do versus what we do now? So Wes and Laura, why don't you tell us a little bit about what the protocol is in your office, from the perspective of new patient to the hygiene chair to to the surgeon. When do you use each one of those things? And then I'll kind of go through what I do with my hygiene team, and let's then talk maybe a little bit about kind of how that relates to production in the practice. Sure. And how it faces that. So talk about your protocol, what you guys developed. Okay, so when we started our private practice, we purposed that we were going to see all our new patients first, and as far as the doctor seeing the new patient first, let's reword that a little bit. So patient enters into my operatory. They're either going to be probed by me or the dental hygienist. And you can use an adjunctive probe as long as the doctor's coming in and doing the diagnosing. So I would sit down, I prefer to do the first probing.
Yeah, me too.
I sit down, I do the probing, and I don't do a PSR. I do a full comprehensive periodontal exam. I do 6 points on every tooth. We chart bleeding, we chart recession, we chart mucogingival junctions, we chart mobility in teeth, and then based on that, we decide whether a full mouth series or vertical bite wings or Panorex and 4 vertical bite wings or just regular bite wings are taken. It's based on the periodontal health of the patient. And so from there, after, you set the patient up and talk to him, talk about, well, what's going on here and what type of diagnosis, either they're going to get a diagnosis of, well, you have gingivitis, Okay, and this is how I'm actively doing it. Now, it's somewhat changed a little bit over the years, so this is my current protocol. So they're going to get a diagnosis of either gingivitis or what we consider a gingivitis treatment of gingivitis. Okay, so we're actually going to do something to treat the gingivitis, and we'll talk about that in a minute. And then what about treatment of hard stain? Okay, and then also we're going to move up from there and we'll do a full mouth debridement. We call that a case type 2 in our office. Now that is not an ADA case type 2, that is a office code that I use. So I have case type 1, and then let's say I have case type 1.5, which is those treatment of gingivitis and treatment of hard stain. And then case type 2 is like a full mouth debridement. We need to do some further things to properly diagnose this patient, remove tartar, to follow up with them in a month and really find out what is going on here. And that could lead to other 4,000 codes. And then a case type 3, 4, and 5 is mild, moderate, and severe periodontitis. Now, those are chronic or acute, or they could be localized or generalized. It just depends on the patient. Now, how that I code those, it's code based on the severity of the gum disease. So it's still the same scale code, whether it's case type 3, 4, or 5 in my office, but the harder the periodontal disease becomes to be is being treated, or how hard that she has to work in the chair, the fees go up. So for instance, a chronic generalized mild periodontitis in our office, case type 3, is not as expensive as a chronic generalized severe periodontitis. And so we might schedule an hour per quadrant or an hour per 2 quadrants for a case type 3, whereas that might be an hour and a half for a moderate or severe case. And you all know that that's kind of tough because we did that. Now, the fees don't vary that much. I mean, we're talking about going from $750, maybe, let's just say, I'm throwing out some numbers here that aren't like accurate to what I'm saying, but like $750 for a case type 3, and maybe a case type 4 would be like $1,250. And so you can see there's a considerable jump when it comes to the money, but it's not like surmountable. Okay, so we've done that for years and found that, well, acceptance has been really good. We've had great acceptance of treatment of periodontal disease. It's very rare in our office that we have someone not accept treatment for periodontal disease. Now, another way that a patient becomes a periodontal disease patient or being treated for periodontal disease is, let's say you have that patient that is being checked in a routine periodontal exam once a year. And what I'm saying is that the hygienist, Laura, for instance, once a year will do a comprehensive periodontal disease check on everyone. Mm-hmm. Okay, so that's a scheduled thing. That's something that's scheduled along with their periodontal maintenance, or if they're an adult prophy. Well, what if you run into some pocketing?
You should clarify that periodontal maintenance is probed, full mouth probing, every single appointment, whether they be 3 months, 4 months, or whatever. So I just wanted to specify that, not just once a year for a periodontal maintenance patient.
So whenever we see that there is an issue, we would be able to go ahead and take care of that by adding more 4,000 codes. So we're going to treat, say, 1 to 3 teeth per quadrant. So, for instance, as an example, patient shows up, they've been an adult prophy, say, all their life. Okay, they're a 6-month patient, and we're probing them that once a year, and it just so happens there's some 4s and maybe even a 5 located in one quadrant. Well, what are you going to do? I mean, that's the question. What are you going to do? Well, the proper thing to do would be to set the patient up and explain to them that there is something going on here. We need to figure this out. Let's get the doctor. So the doctor would come in, the hygienist would work together. And I like what John said at the beginning of this, his hygiene team and him. So it's a team of people. And I like to think of it as like a triangle. And so you've got the patient, the doctor, and the hygienist, and they're in constant communication about their gum disease status because nothing...
Patient being at the top.
Yes.
Doctor and hygienist.
Excellent. Good job. Yeah, so you can tell my team is on board with what we're talking about here because she is part of my team. But if you understand that it is a team thing, and we try to teach that to the patient, that what we do in the office doesn't work without your help. So it's a complete team involvement. So I like the fact that John brought up the team aspect of this, because the patient is key to the team. Mm-hmm. And so if there is the need for a new patient to have gum disease treatment, A hygienist then is brought in to introduce them to the patient, and that treatment begins that day. Now, not scaling and root planing, obviously. Now, it might if we had time for it, but it would probably be some education about the type of medicaments we're going to start using for you, and maybe even some hygiene instruction, going ahead and getting that patient going. If it's a regular routine recare patient, then what we're going to do is we're going to actually have that patient involved in the recare interval of where are we going from here as far as what type of treatment are we choosing to take care of these specific areas, 1 to 3 teeth per quadrant, whatever that might be. Now, Laura, let's talk about the success of our protocol over the years before Jon gets into his protocol, and then some questions about how do we do these things.
Okay, exactly what do you mean by success?
Well, success, like, for instance, have these patients, whenever they've accepted this type of treatment, because the approach over the year with Perio has moved from let's refer this out. You have pocketing. Let's refer. Let's not scale. We're not scaling in our office. And what we've done is we've brought all the periodontal treatment pretty much in our office. And how has that worked?
Okay. I would say that, we have 3 hygienists in our practice. And I'm not bragging on myself. I'm bragging on my colleagues. They are fabulous. They do a really great job. They're very in tune to finding and treating periodontal disease, and they're very well trained. So I would say that we see 95% or more of our perio patients, and I would say that we successfully treat the majority of those people. It's very rare that we have to refer out. And I don't know, I feel pretty good about the protocol that we have going on.
Well, how do you know when to refer?
Well, whenever I bring someone in and we've got a problem, typically I can treat them that day. My mode of action in most cases is to clean the area with the piezo. I like that it irrigates. It's great if you can also irrigate it with a Paradex, but research has shown as long as it's irrigated in some way, even if it just be with water, you're going to get some really great results. So we'll clean it very well with the piezo. I like the piezo also because the ultrasonic waves actually kind of explode the cell wall or damage the cell wall of the bacteria. So you're not only getting, the debris broken loose from the tooth and flushed out, but you're actually helping to destroy some of the bacteria in that pocket. So that's why we choose that. But I'll treat it that day, usually. And then I'll bring them back no earlier than 3 weeks. I like to go a month, but if there's time constraints or whatever, then I can go 3 weeks. On that appointment, I will probe it again. And if it's successful, which most of the time, if it's a 5 to 6 millimeter pocket, even sometimes 7, you'll get pretty good success on that first appointment. If it's not successful, then I'll give them 1 more month of treatment. Sometimes it takes 2 to 3 months to be able to get, full healing from that. If at the end of the 3rd month, I'm not getting any improvement, then I will refer out. I should also say, though, that if at the end of the 1st month the pocket got worse, I will treat them and bring them back in a month. If at the end of the 2nd month the pocket got worse, I will immediately refer at that point. If it's stable, though, and just not improving, that's when I'll go into that additional month.
Now, can you speak to we obviously have learned a lot about Perio, and that there's some point in time we have to actually fish or cut bait when it's time to take a tooth out and just do a graft and do an implant. We know implants are successful, and why mess around with just continued lost bones? So you and I have kind of got to a point in our practice where we say, you know what, it's probably best that we just go ahead and take this tooth out. It's refractory in nature, or it is a situation where a tooth maybe is it's the result of its own issue. It might have a furcation involvement that's really hard to treat. How have we changed in the respect of let's just take the tooth out and move forward with the dental implant therapy? And how's that come across to your patients when you've seen a situation like that?
I feel like our patients, The majority of them are very changing with the times, if that makes sense. I guess they trust us, and so they know that we have done the research and that we're going to deliver the best possible care for them. And even though it is losing a tooth, it's also gaining a tooth. So you're losing a problem and you're gaining a solution. We used to, say you had 7 or 8 millimeter pocket with a furcation, and you can stick your instrument all the way through and out the other side. I used to just really work on it very diligently every 3 months, and say, we've got to keep that tooth in there. We've just got to work on it. And, sometimes it may start to affect the tooth beside of it. Well, then I would just very heavily treat that tooth beside it, and I would, I used to recommend Peridex quite often. And I no longer do that unless it's a really bad problem. Peridex creates so much staining. And if you're constantly removing staining every 3 months, that's a lot of abrasion on the enamel. And the people don't really like that there's Peridex stain all over their teeth. So what we've been doing very successfully is treating with sodium fluoride. It's antibacterial. And so we'll put our patients on a sodium fluoride, prescription dentifrice the whole time they're going through treatment. It lowers that bacteria level. It creates healing inside their mouth, and it's also helping to strengthen those root surfaces that have been exposed, decrease sensitivity. I swear by it. It's a wonderful solution for that. But anyway, instead of doing all of that work all the time in a solution or in a situation where eventually that tooth is just going to have to come out, I think once we see that it is that situation, instead of continuing it, we go ahead and fish or cut bait.
Right, we extract it.
We cut bait.
We extract the tooth. So, Jon, these things have kind of worked for us over the years. We very successful Perio protocol. Do we refer? I refer occasionally for a patient that we have an issue where we want to save teeth and we find it necessary for flap surgery and those type things. I think the thing to speak to is you and I talked about the amount of adjuncts out there. Laura just spoke to the fact that we use very little Peridex in our office now, which is kind of mind-boggling. We're using sodium hypochlorite. We're using a CTX4 treatment rinse. Sodium hypochlorite bleach. It's a diluted bleach, and that has sodium fluoride in it as well as xylitol. It's pH balancing. So we're putting all of our periodontal patients on that for 30 days. That's usually twice a year, up to twice a year. They are on a dentifrice, so they are using some medicaments, 5,000 parts per million. Again, pH balance, that type of thing. Prevident might be one of those that you might have in your office, or something like a Clinpro 5000.
If I might add, he just mentioned pH balanced. The majority of problems, periodontal problems, caries problems, is a result of an acid mouth. And we've, on a routine basis, check our patients now for the pH of their mouth. And I would say on average, the majority of people are around 6.3, 6.2 pH, which is acid. Anything below 7.2, 7.4 is constantly in a acid environment. So all those acid-loving bacteria are just going to thrive. And so the medications or the adjuncts that we recommend are all in the 8, 9 pH level. And I've seen people have no treatment at all, and they'll go from having just the initial exam with him, and I don't know, that 2 weeks, maybe even less, that it takes for them to get into my chair for treatment. In that amount of time, I've seen a 50-60% reduction in just the inflammation and the problems that's in their mouth, just having them in a alkaline situation. So anyway.
So some new things there for you. We don't use PerioChip any longer. We don't use any type of Arrestin. I know Jon uses some Arrestin in your office. I used to place minocycline spheres all the time, especially on smokers. I will use some type of diode laser, but very rarely. That mainly just used to cauterize tissue and to go down and debride like a really nasty pocket, to let that hygienist get down in there and really deep scale that would be for deeper pockets. But that's really the only laser adjunct that I'm doing, and I'm not charging really anything for that other than the scale and root plane fee, 1 to 3 teeth per quadrant. I could be charging flap surgery for that. That's a closed flap surgery. So we could talk all day about perio protocol. What's your thoughts on this, Jon?
Well, a lot of things we do similarly. Some things we do differently in our office. We have my practice is very different. From the standpoint of I took over a practice, and so there was still. This practice has been a long-standing practice, and so it was a practice that still has patients that began with the practice back in the 60s and 70s, and so very different day and time.
So
as
age
far as
of your patient population, tell me that. Kind of describe that a little
average
bit.
is in the high 40s, and so we've got that's come down as it usually does. A lot of times you see, as most practice management people tell you, that the age of the doctor, usually you start to see patients averaging around that age over time. Just that's kind of the circles that you end up in, and so patients end up being coming from those. But I came into a practice that had a lot of older patients, and that's gradually changing a little bit at a time, but still have a lot of older patients, and a lot of those older patients have been in the practice a very long time. Some of them, were never. They didn't even know what perio programs were when there was no such thing back in the 60s and 70s. There was very, very little understanding of periodontal treatment and really even causes of what it was. So kind of today where we are is we have a mix of patients who are very, very well educated about that. And we still have some patients that, come in, haven't been in the practice for 10 years, but have kind of been in the practice for 30 years. And, remember... I went, back in the 70s, I went here, and I don't know even what you're talking about when you talk about this gum disease problem, because, I know it's been 10 years since I've been in the practice, but, I'd always been here before. So we definitely have a big mix. And so our protocol, very similarly, we see patients, quickly here. We see patients, the doctor sees patients first, just like in your office. I like to do the first probing. We do full mouth probing, but we don't full mouth probe everybody, and so that's a little different. I look at I do a little differently. We take an FMX on everybody. We don't. I've been caught many times before not seeing a periapical problem or resorption problem or something because I haven't done that. So a new patient comes in now within reason. Obviously, if a patient is, in their 20s, has had no dental history, we're not just going to plow into an FMX.
So that's the difference too between Jon's practice and my practice. My practice, the average age of the patient is 35.
Yeah. So you got a lot of people that don't have a lot of dental history.
So, if you look at that, if you're out there right now and you have it'd be interesting to see, maybe in the comments down below, say, hey, how many full mouth series are you taking on your new patients? And look at the age, because the older they get, the more FMXs you're taking.
Exactly. And that's why I would say, we don't just say everybody gets an FMX by any means, but we definitely see a lot of older patients and that's why. Yeah, they've had basically almost any dental work, and a lot of them are going to be, even if they are in their 30s, we try to look at caries risk, of course, and we try to look at previous history, but in general, we default a lot to FMX because we feel like it gives us most information for the time. So I'm not necessarily probing beforehand. Now, sometimes you probe or you get those first bite wings, you realize you need verticals, and so I've definitely had that happen for sure, but I typically probe after we have radiographs because it gives me an idea of where bone levels are, and it tells me a lot about a patient, because sometimes you do have those younger patients that do need to be full mouth probe, absolutely, and then you have sometimes patients that are have perfect bone levels, and we still do absolutely a PSR type screening on those patients, and sometimes even full mouth probing if we see any recession issues, things like that. But, bite wings, as you guys know, give you a really good idea of kind of where you're starting and whether or not you need to be concerned. And then you can also look at things before you've even seen that patient, medical history-wise. If you see smoking and poorly controlled diabetes on the medical history, then we're already probably aiming for vertical bite wings, and we're already talking about perio from the beginning. Yeah. So, that's kind of how we do things. We do FMXs on most all patients, and then we probe full mouth on all of our adult patients. And depending on the risk and the history of the younger patients, we may do full mouth probing? We may not. We may do a PSR, make sure there's no pockets, and make sure bleeding is within normal limits. And definitely our diagnosis is very similar to yours. We are always talking about localized versus generalized. We're talking about mild, moderate, severe, chronic, perio versus are we talking about, acute problems. And then what we do, kind of our protocol is, we spend a lot of time just at the doctor's appointment talking about perio, because I want my hygienist to be set up really well for where they don't have to spend a ton of time on education. Not that we don't want them to, because they will, but to where the patient knows when they show up at that hygiene chair for scaling and root planning that they're ready to roll and they know what it's about, and the hygienist can get going.
That's really helped us too, because you and I explain things very similarly, is that whenever they arrive in the hygiene chair, they've already heard it once.
Yeah.
And they're ready to go. It's like, what are you here for today? Oh, Dr. Mullins told me all about this. I'm ready to roll.
I love when I sit down to explain something. They're like, yeah, Dr. Mullins already told me.
Yeah, that's a great, that's a great
thing. That makes it easy because the hygienist can get going. They're not fighting an uphill battle when that patient, what are we doing today? And we were scaling, what's scaling and root planing?
Right.
And so,
so we do that. We spend a lot of time talking about educating them at that first visit. And, sometimes if we got a lot of restorative and a lot of perio, that can be a pretty involved visit. Sometimes you even have to bring them back for more education. And sometimes I have to lean on my hygienist to educate because they might have a lot of other dental issues and I have to spend my time talking about a lot of other stuff. But I try my best. I never want a patient to show up for that hygiene visit without knowing why they're there, what it's about, and have the hygienist get set up to where they're going to be able to do what they need to do without having to have the patient say, "Why am I here?" or "Why are you talking about anesthesia all of a sudden?"
Right.
That kind of thing, because that's a nightmare. So then, as far as our protocol for treatment, we are I think per standard protocol doing scaling when scaling is necessary. I mean, that's a pretty straightforward thing, and we budget time just like you do, depending upon if it's a difficult prophy kind of situation with a lot of stain or severe gingivitis or poor hygiene, even, just poor compliance.
Let's kind of tackle that right now for the next minute or so. You and I have talked about this. They've eliminated the adult hard prophy, and I've actually added codes adjunctively to make up for that, because there is no hard stain and there isn't a treatment for gingivitis.
Right.
And you can have threes and there be severe or generalized gingivitis. There is no severe. It's either gingivitis or not, people. So that's a pet peeve of mine, is that you don't have mild, moderate, severe gingivitis. You either have it or you don't, because gingivitis is a description of the condition of the tissue. It is a description of inflammation of the tissue. And so you could have a total generalized gingivitis with tissues are red everywhere, plaque everywhere. The hygienist needs a ton more time for that patient.
Sure.
So how do you can't, that's not a healthy cleaning. That's not an adult prophy. So John, how have you handled that in your office?
Yeah, same as you. And we've talked about this before, is that we had to, for several reasons, add a code, because several reasons. One was, the main one, honestly, was you might think out there who's listening, you might think it's money. The main one is ownership. I want the patient to own their problem.
Right.
And if they refuse to brush their teeth,
I've never had somebody deny that treatment.
No, they understand. I mean, if they refuse to brush their teeth or floss or use the water pick or whatever it is that we recommend that they do, if they refuse to do it, that's a huge thing. If they smoke cigars and they've got a ton of stain, whatever the reason is that we're spending all that time, I want them to own it. I want them to be the one that says, "Hey, I know why I'm spending that little bit of extra money, because it's my problem." And, the hygienist, I want the hygienist to have the option of saying, to this patient, I can work for an hour and I can take care of your disease, but we can leave stain. Or I can work for an hour and a half and I can take care of a disease and your stain. Or you can work on your stain at home and we can do it all in an hour, and that'd be awesome. And the patient really owns that, and I love it because the patient is the one in control of that. And it also, from a practice management standpoint, you can't spend an hour and a half and charge for a 1110 and get that. I mean, the hygienist is being paid for another half hour of their time. They're getting paid hourly. We have to charge accordingly for that, or else we're losing money. If you are contracted with a lot of PPOs, you will absolutely be losing money if you spend an hour and a half. So your choice is, do you do subpar treatment in an hour and just put everybody in the same thing? Or do you do the right treatment, but you can't just charge a 1110 and expect, you charge more for a 1110, insurance is going to pay you the same.
That's right.
So you got it. And I think it reflects better too. And we've talked about this on your 4,000 codes when you do your practice management analysis, which we'll talk about later, that you want to see those 4,000 codes, knowing that these people, you're treating gingivitis. So we definitely have added a code, and I think it's helped a lot. And patients, I think, do understand it. As far as referral in my practice, same with yours. We treat most perio in-house when it's appropriate. And I feel like when it's appropriate is when we're seeing response.
That's right.
And when we have a patient who is, whether they're doing their thing or not, it's really not important. It's whether we're seeing a response. If we see no response, what do we do? If we see 6s, 7s, 8s, and we're not seeing response, well, we know that that's either the patient, or we know it's a systemic issue, or we know it's a bacterial issue. There's a lot of stuff from AAP, American Academy of Perio, about what to do then. And we don't have time to go into all that, but systemic antibiotics sometimes are indicated. Long-term systemic antibiotics are sometimes indicated. My use of Arrestin is pretty limited to situations where we have a mouth full of bleeding on probing, and then we do scaling, and then we have 2 teeth that are still bleeding on probing with 6s and 7s, and we're going to try to do that rather than doing surgery there. So that's usually where we'll use it. If we've already done scaling, we come back, we re-instrument the area, we still don't see response, and we don't want to go the route of surgery. That's where it's sometimes, and that's, I think, the only, anybody that's using Arrestin like full mouth, it's crazy. The research only shows maybe a 0.5. Link me an article. It's only maybe 0.5 to 0.8 millimeter improvement in attachment. It's not really tremendous. So I think that it can be good in certain situations, but we don't use it a lot. And we do see success from our protocol as well. I mean, it's a lot of it is perio can be successfully treated. You just have to educate the patient and have a hygienist that's well trained, and you have to believe in it, just like all this other stuff. You can't just say to the hygienist, start talking about perio. You need to spend, if you're not doing this in your office right now, what I would recommend personally is that you call a practice management person on this one. If you're not doing perio in your office right now, man. Because if you're not doing it and your hygiene team doesn't really know how to do it and you don't really know how to do it, call somebody up who's quality. Call somebody up like Sandy Pardue or Sally McKenzie, somebody that's been doing it a very long time, and say, hey, look, I need a soft tissue program in my office. I don't know how to do it. And don't just get a phone consult. Bring somebody into your office who's an expert, who's a third party, and have them educate you and your staff, and get that set up in your office where you're not sending these patients out. And the worst thing you could be doing, and this will get into our next segment of the show because we really got to go to that next segment, or else we're going to be talking for hours. But the worst thing you could do is to tell your hygienist who's motivated and really wants to do a good job, if to just lay a sickle scaler in the room and say, you got 30 minutes, do what you can, and almost act as if perio doesn't exist.
Well, let's go right into the rant of the week, because the rant of the week is ridiculous. I'm just going to say it. It's stupid. Why in the world would you even be able to practice? We don't probe. That hurts the patient. Now, Laura can tell you from firsthand experience, she has been in situations where she was told 30-minute prophy, do what you can, get it done. And I want her to speak to that, because we don't probe. Listen, now, the number one lawsuit in dentistry now is failure to treatment plan dental implants.
Yep.
The number 2 malpractice lawsuit in dentistry is failure to diagnose periodontal disease. Yep. The number 1 reason people lose teeth today is periodontal disease. I just took out 25 teeth on Friday in a rural extraction clinic. And guess what? Every single one of them was periodontal diseased.
Yeah.
Every single one.
Yeah.
And so why are we not treating it? I have no clue. And the care is just diving. So, Laura, this is a rant of mine. It's a rant of yours. Speak to this. Why are doctors not wanting to treat periodontitis? You've worked in these practices before. Let's hear it. Don't lay into that thing.
Yeah, don't hold back now.
Tear it up.
Bring it.
I have lots of reasons why I think they do. I mean, I'm not in their mind, so I don't know exactly, but I think they don't see it as important. It's not what they have focused on in their career. It's not what they've specialized in. And so it's not personal or to them, and they're not passionate about it. For you to love something, for you to recommend something, for you to sell something, whatever, you've got to be passionate about it, and it has to be personal to you. And so sometimes I think they think, oh, it's just one of those hygienist things. I don't know.
But that's one of our points here, is that it's not the lack of knowledge, John.
Yeah.
Because you have to take periodontal classes in dental school.
Yeah, nobody here can claim that they claim ignorance.
And that's
I mean,
the thing too,
maybe if you graduated in 1960 and you're still, if you're 90 years old still practicing dentistry, we're going to give you a pass. I think dental guys, can we agree, Wes? 90 years plus, you get a pass. Anybody less than 90 practicing dentistry, no pass.
No pass.
No pass, because you know about it. You know what the deal is. You know what perio is. You know exactly what the risk factors are. You know that it has to be treated. You know how it has to be treated. You did it in dental school. You learned about it in dental school. You had, for the boards, what did you have to do? You had to scale and root plane a patient. Everyone has to do that. And you were graded by how effective your scaling root planing technique was. And all hygienists are graded the same exact way. So there's no excuse in terms of not knowing. So that you can just throw that out immediately. Yeah. So what is it all about? And I think Laura has hit on a lot of it, is that you're not passionate about it. I think that there's this mindset maybe of that's not what drives a practice. That's part of it. It's that's not, they think that restorative is what drives a practice from a money standpoint. And I think we just have to dwell on that for a second, is that a lot of this is money. And They think that there's this thought that you will not be as productive if you spend your time talking about perio.
That's just not right.
If you think about all the work that you dentists put into the beautiful crowns and the beautiful restorations, and all the time and focus you put into adjusting occlusion and just making sure everything is beautiful and perfect. Well, if you're not treating perio, eventually those beautiful, perfect things are going to fall out, and they're not going to have any teeth to treat. What do you do then?
Right, and I think that too. I mean, it's a fallacy. Even if you are the guy that's just money driven, let's just for a second, let's pretend like it's all about money, because for a lot of people it is. So for a second, let's just go down that road. What does a hygienist produce in an hour that does only prophies compared to what a hygienist can produce in an hour doing scaling and root planing? It's off the chart difference. And so you can take, if you look at benchmarks from what hygiene should be doing percentage-wise compared to the doctor in the practice, and you look at how much of that should be perio, somewhere between a quarter to a third of your practice should be hygiene. And I can almost guarantee that those practices are either, number one, not having that kind of percentage, which means their hygienists are producing very low per hour, or, and this is really scary, this is where it gets really scary, or they are producing, but if you're not doing scaling and root planing and your hygienists are producing a lot per hour, what do you have to be doing? Seeing patients in 15 minutes, putting a sickle scaler and an ultrasonic in the room and saying, this is what we do. Just roll through it.
That's crazy that even goes on. Like, I'm gut wrenching that you even said that.
Well, I know it goes on because my associate was looking at practices before he met me. And he was at a practice where what they did was, it was just the mill, PPO mill, and they gave their hygienist promise, this is the truth, 15 minutes, ultrasonic and a sickle scaler, and they polished the teeth, and they said that, and they, of course, diagnosed a crown, please, for me, please, during that 15 minutes so the doctor can get some production. And so, you charge full fee, 1110 for that. And so the hygienists were, and it was assisted. They had an assistant in there, turning rooms over.
So
that's the only way you can do that.
Producing, crazy dollar amounts per hour.
Yeah, they're producing what like a good hygienist doing good work would produce in an 8-hour day, seeing 8 patients. But they were seeing like 20 patients, 30 patients.
That is malpractice.
No question.
That's
so these patients, but this is all over the place. This is all over the place.
And see, it starts with the public too. And we heard this out at Speer Education. the patients aren't aware of what really truly needs to be treated. They call and they're aware of the fact that they need their teeth profied. And so if they get their teeth polished, which we know does nothing for the periodontium.
And you actually shouldn't have your teeth polished every appointment.
Whoa! Did
Yeah,
you just hear what she said? And she learned that, 12 years ago, people?
Yeah.
She just said that you don't polish the teeth. You shouldn't polish the teeth every 6 months. Why? Because you remove enamel. You remove enamel, and much less Gordon Christensen's wife, what's her name? Rella Christensen did a study, and it showed that most hygienists, when they polish too fast, and they ding the root surface. Yes, the enamel will remineralize.
And they use a coarse paste.
The coarse paste and the ditching of the root surface is irreplaceable. It will not remineralize.
But that is, to the patient, the perception is that
That's what
is
they
their
want.
cleaning.
That's what they're aware of.
The
So
polish is what they expect. So if you don't polish the teeth, you didn't do a prophy to the patient. But if you didn't scale the teeth, they don't know. And so they think that is really like, they don't even know what that is if you don't educate them. They just associate that. I mean, if you didn't polish, the patient would think they didn't get a cleaning. Which is so
I can
crazy.
tell you, the majority of our patients, they want that polish, even if we explain to them.
Of course they do. Of course.
We do have some people that are like, okay, don't do it. But so what we do is we'll use a non-abrasive fluoride dentifrice, and we'll just we'll polish their teeth with that. They feel great about it. We feel good about it, and everybody's happy.
Hey, John, and I know you love whenever that patient leaves your office that's been a full mouth reconstruction, and they go out the door and you're like, see ya. And they're like, and they call in, they say, we just got relocated down to San Diego, which is on the other side, the West Coast. And you're thinking, call the hygienist and tell him not to polish my crowns.
Right.
Because what doesn't remineralize? Glaze.
Right, exactly.
Glaze.
All that nice stain that we spent all that time, trying to get perfect on number 8, because we had to custom stain it. Now that's gone.
It's gone.
But that getting back to the perio part of that though, I mean, if you think about what's really going on in these offices, I mean, let's bring it back to, why we're ranting about this is this because, we actually, even if you're, again, money driven and that's your whole thing, you will make more money. Yeah. You will make more money. I guarantee it. You do that. You get a soft tissue program going in your office. You believe in it. Get hygienists who believe. If they don't believe in it, get rid of them. Yes. If the hygienists do not believe in it, get another hygienist.
And a lot of times that's hard, guys. You got to fire somebody that you try and you say, look, we're going to start treating perio. If they buck the system, see ya.
Done. Yeah, that's it. And that's going to be hard.
Fine.
But get somebody in your practice to get a soft tissue program going, and then I guarantee you, give it a year, you will have some patients that will buck it. You'll have some hygienists that might buck it, but you will make more money. So even if that's what you're about, do it if you're doing it for money, you're still going to win out. I feel like that's the thing about a lot of dentistry that we talk about this stuff. People have this mindset of like, oh, it's not as profitable. It's not as productive. It is more profitable and productive often to do the right thing. Sometimes it's not. Sometimes you're doing it because it's just the right thing. But it's actually going to make more money for you in your practice. Your hygienists are going to be happier because they know that you're doing the right thing. And your patients who won't know if you're not doing the right thing, they're the people that are the ones that won't know. You're going to know. The hygienist is going to know. So if you're not sleeping well at night because of that, I hope you're not sleeping well at night because of that. And if I know your hygienists are not working as hard for you, if they don't believe that you want good periodontal health for these patients. I mean, Laura, how would you feel as far as your motivation level? Could you work in an office like that, knowing what you know? Could you work in an office like that? Because a lot of hygienists are in that situation, I think, where they're trying to figure out what to do. How do you handle as a hygienist? Do you leave, or do you talk to the doctor? I mean, that's a big loaded question.
That is a great question for you. What would you do if you were in a situation where you wanted to practice high level dentistry or actually just regular great dentistry?
Yeah, just standard of care.
Standard of care, and the dentist wasn't. What would you do?
I've maybe semi been in that situation before. Excuse me. And I did it anyway. A lot of times dentists don't care what you're doing as long as the patient's happy and you're not hurting people or whatever, usually they don't mind. And so whenever I started seeing problems, I would just bring it to the dentist's attention and he would say, okay, you want to treat it, treat it. And I would treat it. And really, he kind of got to where he was helping me see these problems, and we were treating them together. It just depends on the mindset of the dentist that you work for or the dentist that you are, if you're open or not to that. Just know if you're open to it, it is going to only benefit your practice. Just one thing that I was wanting to say through just listening to everybody, if you're not doing perio in your office and you're referring it out, say you're screening for it, and you're just not doing it in your office, patients are much more likely to accept the treatment if it comes from you or from your office. That I have found. There are several times that I've been working on a patient, and I'm like, this tooth really, I'm not sure that I'm going to be able to help it. I think I'm going to have to refer you out. And they will beg me to do everything I can to keep them in our practice. Occasionally I still have to refer out, but they trust us. They know me. It's just like getting your hair cut every 6 months. You know what your hair is going to look like when you leave, and they know us and they trust us. And so they would rather stay in your practice than go somewhere else, even if that person's great. So we do it not only to better our practice, but because it creates more trust in us from our patients.
Yeah, and I think that's great. I mean, because that's really what it's all about in the end, is that patients the reason they're at your practice, and of course they brought this up at Speer, so I mean it's good, it's just fresh in my mind that why are they at your practice? Because they like you,
right.
Because they like you. And the reason that they come, I mean, some of them, yes, are just there because they're insurance, but if you're doing a good job, they like you. And so if you can keep this in office and you believe in it and it's clear throughout, you're going to benefit from it. And again, I just, if you're not doing this in your practice, or if you're maybe an associate struggling in
or you're
in
a
practice,
PPO. I mean, you're in a PPO situation. Where
you got to figure this out. It's not something that you can ignore. There's some things you can ignore. You can say, well, I don't want to learn about veneers. I'm just not going to do veneers. That's really okay. You can choose not to do that. You can refer to a prosthodontist for your tough dentures.
But what we're talking about, John? We're talking about treating a disease, just like we're trying about treating caries.
Yeah.
You are ethically obligated to treat a disease. Process. That's why it's the number two lawsuit in dentistry.
And you have the knowledge to be able to treat it.
Yeah, you know everything you need to know. Maybe you don't know how to institute it, but you know the basics. And so just get somebody in your office to institute it. If you can't do that yourself, your hygienists are not, ready to go, figure out a way to do it. And don't be that office that everyone talks about in town, or the people who are good talk about in town as a place that you never want to go, because the hygienist, it's a revolving door. They hate their job. These are the offices where there's embezzlement going on, where the hygienists are just all about money because they know that it's not about the care. So it's going to be about something. What is it about? Don't have your office be about that. Have your office be about, like Wes said, taking care of the disease, taking care of the patient. Is pretty straightforward. So that's the rant of the week. Wes, I know you've got the product of the week for this week.
Yeah, my product for the week, and we'll say goodbye to Laura. Thanks so much for the comments.
Thank you,
there,
Laura.
And
awesome job.
Pretty sweet. Awesome sauce. So product of the week is, I'm really excited about this. It's very rare, and John knows this, and dental guys should know this, that I rarely change composites. I rarely change bonding agents. And probably about a year and a half ago, Filtech, 3M per se, came out with bulk fill, Filtech. And at first, I wanted to kind of go behind the scenes and find out what was being done at 3M to create this product, because they did have Filtech LS years ago, which required a special bonding agent.
Right, the whole Silarane ring thing, real complicated.
It was very difficult to manipulate.
It didn't really have the low shrinkages. It was different, but it wasn't hugely different.
No, and I never did subscribe to that composite. I'm a Filtech Supreme guy from way back when, and have been that way for a long time. So I've been placing nanohybrid composites, both in the posterior and the anterior, and so whenever you go to change a composite, that's a big deal. And so my product of the week is the product that I changed to for my posterior composites, Filtech Supreme Bulk Fill. And let me just say, amazing. First of all, let's talk about depth of cure. Depth of cure, reality tested, 97% cured. Now, curing for 40 seconds with a good light, Epilar or even like the Ultradent light, something like that, 40-second cure, 97% cure at 5 to 7 millimeters.
Yeah,
that's crazy.
They show that it really was. Now they did have to, like you said, reality found. Yeah, you had to cure a little longer.
You had to cure a little longer.
But man, I mean, it validated the claim that it really can be cured much at 5. That's
and
crazy.
have low shrinkage. That was the thing. So you have less stress on the surrounding tooth structure. And that's what we're going for here. That's going to reduce sensitivity. Now, the thing is like, well, Wes, you probably had increase in sensitivity because we've been doing bulk fill for years just with regular composite. Well, you're not doing proper protocols then. Layering techniques and using special, just layering techniques alone are adequate. And we'll not talk about tips and how to pack composite, but what I'm going to tell you is that my sensitivity has not increased. In fact, it's decreased. Now, how's that possible? Because it's less shrinkage than Filtech Supreme Ultimate. And so I'm seeing less shrinkage, less sensitivity. Now, we all have sensitivities. You're going to have sensitivity with composites. You're going to have sensitivity with amalgams. Sure. And so I don't place amalgams. I do place all composites in the posterior. And I do use proper protocols for that. And I recommend Filtech Supreme Bulk Fill. The aesthetics, let's talk about that. Now, it is a translucent material. So when you place this, you are going to see a little more show through than you would in your standard materials like a Filtech Nano Hybrid or something like that. So you're going to have more of a translucency there. And they had to do that to build in the curability. Okay? So you're not going to have that chameleon effect per se as much as you would. But does it look good? It looks fantastic, and patients love it. They can't tell a difference. Only I can with my 3.5 power loops or John's 4.5 power. You can't use it in the anterior. It doesn't have, you like that? I threw that in there.
Yeah, I'm glad you brought that up.
A little polishability. The polishability is, I would say, let's just say if we had polishability of poor, fair, good, and excellent, I would say it's good. I would say that with proper polishing protocols, you can achieve a very good polish. Now, this is one thing that I was pretty big up on when I talked to 3M. They spent a long time with polish retention. And so what I'm seeing at a 1.5 years out with Filtech Supreme Bulk Fill is excellent polish retention. And obviously, if you need to go back in there and hit this with some type of a brush, a pogo point, some type of a product, whatever that might be, go back in there and do that to enhance the polish. Layering technique. Now, there is one thing that I have done to make things look a little bit better. Say you're in a premolar situation, a high stake patient. You may not want to use Filtech Supreme Bulk Fill. You may use it in the box, but then on the occlusal aspect, you use Filtech Supreme or a Nano Hybrid, something that has a little bit more block out ability, something to block out maybe some dark staining or something like that. Again, that has more of a chameleon effect, has more of opacity built into it. You can do that layering. So you can mix it back with something that is a little more opaque. John, you blew my mind on the plane when you told me that you had switched to Filtech Supreme, because I know how few materials that you switch to or switch from.
I'm like an old man, Well, I don't.
When it works, why change? You know? And that's what a lot of you are saying out there right now is why would you change? And so, John, you changed.
Yeah, and I don't change. I mean, I'm not. Just like Wes is a longtime Filtech user. I've been a longtime Estelite user by Tokiyama. I like their product a lot, and I've used that product for years, and Ray Bertolotti got me interested in it, and Speer also, and I really like it but it was always doing the typical 2 millimeter increments, just like we were all taught, and I think it's been validated for years that that's still legit, even with high powered lights. So when all these products started coming out, I was very skeptical because, and most of them, the issue is that you had to cap them with something, so
that's right.
Who cared? I did not care how good it was at depth of cure. If I still had to put another composite over the top of it, that wasn't really a huge savings of time. It definitely wasn't a product savings, maybe a slight difference in time. Now, I know guys that were using it the wrong way, the old stuff. They were using like SDR flow, and they were just filling the whole thing up with it, and they weren't capping it with anything. And that's not the protocol. that stuff is not. It doesn't have a good wear.
That could be a rant.
Wear rate, yeah. So I don't want to get too far into that, but just suffice to say that all these products coming out, I was just like, yeah, whatever. This stuff's ridiculous. Why would you use this? The only reason I could see people using it is for the wrong reason, which is to fill it all the way up to the top and not have to, and then it's going to wear out and they're going to get to replace it in about 3 years. So, wow, that's great. So then when Filtek came out, again, I was very skeptical about it because it's the first time anyone ever said, because Filtek had another one who'd come out that was a flowable,
right?
That was designed like SDR Flow to just be
junk.
used in the box. And yeah, it was junk. It was just the same as all the rest.
Right.
But so when this one came out, it was like, wow, you can use this as the final occlusal, this can be
it.
this. Yeah, I mean that's pretty crazy. And so, when I saw that, I thought, well, okay, so this is something I can use. But I'm very skeptical. It took me a while. I had to prove to myself through looking at research, through reading, what I could about this. And I'm usually a guy that wants to see 5 years of research at least before I switch to something. But I was just hearing so much good stuff about it that I said, well, let me try it. Let me see. I'm probably going to have a lot of sensitivity. I was very skeptical. I had no sensitivity, had no problems. I love the way it handles. I've tried Sonic Fill before. It handles very similarly to Sonic Fill.
Which we'll say is the main competitor here right now. There's only two really on the market right now.
Yeah, and I think Sonic Fill's a good product too. If you like Sonic Fill, hey, great. Keep using it. I think Sonic Fill 2, the new one, is even better. It's supposed to have a little bit better qualities, a little less light sensitivity, which was the issue I had when I tried it out. But, bulk fill, I have no issues with it. None. No sensitivity issues. No handling issues. I like that the little cannula on the compule is far enough. It's just, to me, they really thought this product out. They did it right. Yeah, definitely, man. I gotta give it this, because they did it right, and 3M usually does it right. And so when they research a product and they've come out with something, they usually figure it out. And this is when I think they hit a home run. So, and I haven't seen a ton of recalls yet. I'm just starting to see some recalls on it. But I've not had any issues, and patients are loving it too. I agree with Wes. If you got a lot of stain, like maybe an old amalgam that has a lot of stain dentin, I like to opaque it, either with like an opaque flowable or something over the top of it, because I agree it's a little translucent. Never had a complaint about it, ever. And I just love the fact, like with kids too, I can slam it in there. I can get a light on there. Yeah. I get out of there faster.
Yep.
That's big too. You got a kid, you got an isolite in there or something, or a rubber dam, and you're trying to get out of there fast. That's another big reason for liking a bulk fill. So I think it's a great product. Wes, it's changed the way I practice.
Product of the week, Filtek Supreme Bulk Fill by 3M SB.
So dovetailing into that is my tip of the week. And the tip of the week, those of you who have listened to our other shows know that we try to make the tip of the week and the product of the week kind of coincident with each other. And the tip of the week this week is, if you're going to use a good composite system like Filtek or any good composite system in the posterior, you've got to have a good matrix system.
Awesome.
If you're still using Toffelmeyer,
wow.
I really feel bad for you. I really feel bad for you because you're struggling and you're probably, hating composite.
If you are still using Toffelmeyer, I'll go ahead and put in the links down below some great articles on why you shouldn't be.
Sure.
Why you shouldn't
be. Or at least using the greater curve bands. If you don't listen to anything else I say and Toffelmeyer is amazing, try the greater curve bands because they're pretty good. But you really should. If you want to get predictable contacts,
that's right.
Every time, you have to use a good matrix. And I think there's two main systems on the market that everyone agrees, or most people agree, are the best. And that's V3 Ring. And that's, used to kind of have its own Trios, used to have its own thing. And now that's being distributed. So Ultradent's kind of picked it up, and they have
Dentsply,
Dentsply, yeah. So it's kind of being licensed to different companies. Great product. And then there's Garrison, who also has a good sectional matrix system too. Garrison's product has changed a little bit over the last few years. They used to have like a silicone mating surface of their ring to the tooth. Now they have like a plastic mating surface, which is I find I use the Garrison one. Although I like V3, I think they're both awesome. But I use the Garrison one, and I find that the newer rings, I think they're called the XR, extra retention, they're a little lower profile, they have better grip, and they are also better for wider contacts. And I think that's the big difference I've seen in talking to people like Jason Smithson, who Wes and I both saw a few months back, about matrix systems, who I feel like Smithson's probably one of the masters of posterior composites. And he said he likes both systems. He said, V3 he likes for small boxes, and Garrison he likes for larger boxes, and it has to do with the size of the tines. The V3 ring has real small tines, so it really locks into like small areas very, very well. Garrison is a little bigger, and it's a little wider, so it maybe locks into wider embrasures maybe a little better. Again, they're both good. If you learn how to use either one, I think you can be very, very successful. Both of them will give you money back if you try one ring system and you want to go to theirs. They'll let you try it out, and they'll give you money back if you trade one in. So at your next dental meeting, go by the Ultradent booth, go by the Garrison booth, try them out. They're both good systems, but you cannot be successful, in my opinion, predictably in the posterior without a good matrix system, and just right along with that, some kind of good isolation. Both Wes and I are rubber dam guys. We like rubber dams. We believe in them. I also have really, again, another product that's changed my practice. We can talk about another time. Right. Is Isovac Isolite, but you got to have some kind of good isolation. And if you have good isolation, you have a good matrix system, you got a good composite. I think we're past the days where posterior composites are really all that technique sensitive. I mean, they are. You got to know what you're doing. They're harder in some ways than amalgam. It's worth paying good money for them from the patient's perspective more than an amalgam.
And I hated this argument. Whenever I was buying the Triodent's V3, of course, I've started out with V1, V2, and V3, and these things are expensive. And I remember one doctor telling me, he was like, "Man, I'd like to buy that, but it's too expensive."
Right.
And I'm like, "Oh man, well then you shouldn't be doing posterior composites."
Right. How expensive is a redo because of an open contact?
That's
My goodness, man. How many redos? How many redos before you bought a whole ring system?
So a good, John and I both approve, tip of the week, a good, solid sectional matrix system.
Yep.
V3 is our top vote, and the Garrison sectional matrix system, the newest version out there, both highly recommended by the dental guys.
Absolutely, we highly recommend them. So it's been a great show. We've talked about Perio. We've really hammered it hard. I know that hurts your brain a little bit especially if you're not doing Perio. Hopefully you get interested and going and checking that out. We really appreciate Laura being here with us today too. She did a great job. She's an awesome hygienist. And, we hope, too, that it's changed the way you practice, maybe with some of the things you've talked about today. Make sure that you go check us out on social media. We've got our Facebook page up and going. We've got Twitter feed going. We want to hear from you. If you're listening to our show and you have comments about what we've talked about today or previous shows, ideas for upcoming shows, if you like something we said, if you didn't like something we said, if you're opinionated like we are, we want to hear from you.
Comment,
no matter how... Yeah, that's right, man.
Like
us and comment about what we're doing. One little teaser before we go.
Bring it here. Here it is. This is it.
So we told you.
We
said we were going to go out to Speer and we're going to try to get some interviews. Now, Frank Speer didn't teach the course. It was some awesome guys that did. But we got a faculty member at Speer, I'm not going to say his name, but one of the faculty members at Speer has agreed after listening to us, I think he got it. And he's like, "Yeah, I want to be involved with this. I want to be." So we came up to him and we're like, "Well, come on, man. What can we get you on our show?"
Yeah, can you imagine being us? We're sitting there at breakfast one morning and we were like, "Hey man, this might sound kind of weird."
It's like trying to ask a girl to do a dance or
it was
something,
tough, But then he was so cool about it.
Yeah, you're like, "Do you like me? Check yes or no." And so but he was really cool about it.
And then at the end he came back and said, "Yes, I want to do this, guys." And then a follow-up email. So
said he's excited about it. So we're not sure. We don't have that booked yet, but we're working on dates, and that might be the next show. And be looking forward to that. And we'll definitely be looking forward to that with us. So for John the dental guy and Wes the dental guy, we just want to thank you for listening this week. And as always, we are the dental guys.